And today one must say that 99.9% of all presentations at major spinal or orthopedic conferences or congresses are solely about surgeries. And 99.9% of people, myself included, would like to avoid surgery. And this is really heading in the completely wrong direction.
Welcome to Healthwise, the health podcast presented by Sunday Natural. I'm Dietz Behrens, and in this podcast, we explore together what it means to be healthy. We delve into topics such as medicine, exercise, nutrition, and emotional health, always with a wise perspective on what truly benefits us.
Back pain is the number one common ailment. Almost everyone is familiar with it. Many suffer from it constantly, and often the only solution seems to be surgery. But what if there is another way that works faster, more sustainably, and entirely without a scalpel? Dr. Florian Maria Alfen is a renowned spinal specialist, originally known as a successful back surgeon, but experienced a radical change in thinking due to his own pain story. Instead of viewing surgery as the only solution, he developed a non-invasive method that has since freed thousands of patients from their back pain. In his book, The Back Surgeon Who Couldn't Operate on Himself, he shares his insights into outdated medical practices and demonstrates how almost 90% of all back surgeries are avoidable. Welcome, Dr. Florian Maria Alfen. Hello, I'm glad to be here. Welcome to Berlin. Dr. Alfen, how back-friendly do your Sundays look?
Meanwhile, it's very back-friendly because I can jog again, and I go running every Sunday morning before breakfast. So everything looks very good at the moment.
Very exciting, because I would claim that many people actually get back pain when they go jogging, but we'll probably come back to that later.
That's right.
You are one of the leading back surgeons, and I find it quite interesting how you describe in your book how you attended various conferences and actually got celebrated worldwide, which might sound a bit disrespectful, but nevertheless, you received a lot of fame and honor for it, because you introduced a special type of back surgery, and ironically, you then suffered a herniated disc, which completely changed your thinking. Take us through it. How did you experience that moment back then?
Yes, it was an absolute shock. Well, as you just nicely said, I felt like I knew everything about the spine. I was flying around the world first class thinking, yeah, you're a star a little bit, so maybe a bit of hubris too. And then suddenly I got a herniated disc, and that was unimaginable for me. That was the first thing. The second was the pain, the extreme pain I felt that made me realize for the first time what patients go through. As a doctor, you might find yourself in a position of authority, overseeing a patient's treatment and managing their illness. But when you experience it yourself and see what fears arise and how people suffer from it, it's a completely new situation. And the third thing that struck me was a sense of shame. So I had the feeling that as a spinal surgeon, as a spine expert, one should know what to do or how things are connected. And it was very difficult for me to deal with the fact that I was treating patients without really knowing why I had a herniated disc in the first place. So I was basically the surgeon who had a herniated disc, operated on herniated discs, and the patients would ask me, why do I have a herniated disc? And I essentially had to say, I don't know.
Would you say, how would you describe your feelings? Was it a moment of despair or perhaps even fear? Absolutely.
I understand patients much better today. It was a feeling of despair. Of course, everyone is in a unique social situation, financial situation, or family situation that can suddenly change. And how things will proceed from there, or how they might develop further, or how life will change, is something you cannot assess at that moment. Therefore, you feel desperate. That is exactly the right expression.
Many expect that as a specialist, you would immediately find the perfect solution for yourself, but for you, it was indeed a longer process. Would you perhaps like to take us a little bit, maybe just a small bit, along on the journey?
Yes, well, the first thing was that I couldn't believe at all that I had a herniated disc, just like many patients who are listening to us now don't want to accept it and might even downplay it. Only the symptoms were ultimately so extreme and so clear that even I, who perhaps wanted to push it away as far as possible, had to say, okay, this must be a herniated disc. And just the situation of how I did this MRI was something completely new to me again, because patients often come to me and say, "Doctor, I would like to have an X-ray." And I always wonder, why do they actually want an X-ray? And when I was then pushed into this tube and realized, okay, this is really tight, it's really claustrophobic, then I suddenly understood why they ask why they want an X-ray. Because they didn't want to tell me, well, Mr. Alfen, I might feel a bit confined or claustrophobic, and that's why they pointed to the X-ray. So I suddenly saw and understood such situations in a completely new way. And of course, then the next step is, what do I do about the herniated disc? If you now perform a major operation or an open technique where bone is removed, I haven't done that in a long time. I then introduced endoscopy in many countries around the world, and of course with such a massive prolapse, which I also had, it wasn't just a small thing but a huge herniation. I would naturally have suggested, okay, let's operate on it now because it would be quicker. But I was the expert in this surgical technique and all the others weren't as experienced as I was. So, like most patients, I also tried to avoid the issue. I did physical therapy, took medication, got injections, and this period kept changing, yet nothing changed at all, and that's exactly what many patients experience. We've treated over 20,000 patients by now, as they don't achieve lasting improvement when they use non-surgical therapy, and I experienced the same. In the end, I was so desperate that I said, okay, I'll just get into a machine, which we'll talk about later, and try to use this machine, which is usually only used for treating back pain, so no serious conditions to avoid the issue. And my people, my staff, my therapist said, "Boss, you're crazy to sit in there with an incident. If you push back against resistance, it'll just press the thing out even further." But it kept getting better and better, and in the end, it led me to a completely new insight, which we then researched for 15 years.
Before we delve into the solution, I'd like to briefly focus on the problem, specifically the issue of a herniated disc. Could you perhaps briefly explain to our listeners what exactly is happening, what the incident is, and what exactly occurred?
In the spine, all changes, whether they are degenerative changes, spinal stenosis, or herniated discs, are always pressure phenomena. So, if there is too much pressure on the disc or the vertebral body, changes occur. The intervertebral disc, which lies as a spacer between the vertebrae, just like the meniscus, for example, where the spacer is also located in the knees, has to absorb a lot of pressure. If the deep muscles, which we will discuss later, are not firm, then the pressure on the intervertebral disc increases and eventually the outer layer of the disc tears, the inner core protrudes outward and presses on the nerve root, and that is what triggers these severe pains. The first pain that patients usually experience is simply a severe pain, so it's not like you immediately have a herniated disc, because the disc is interwoven with many nerves, and even a small tear can cause significant pain. So one should be cautious about how to proceed with it. In the case of a herniated disc, it is already a significant nerve issue.
So, excuse me for a moment, I'd like to visualize this a bit. That means you have to imagine this disc like a small gel cushion, more or less, right? So, to put it simply, I'm trying to visualize it a bit. Yes, of course. So, basically, there's too much pressure on this gel cushion, causing something to tear, and part of the gel, in quotes, leaks out even if it's not entirely physical. But as a result, you essentially no longer have the complete buffer, and this allows the two vertebrae to touch, which causes the pain. Is that somewhat well explained, or almost so?
The disc consists of an outer ring, which is a relatively stable fibrous ring, and inside is this gel cushion, which you spoke about so beautifully. And when the outer ring tears and there's a rupture, this gel, which is like a bouncy liquid, leaks through this gap to the outside and presses on the nerve root. The outer ring has so much volume that it's not the meeting of the vertebral bodies that's the problem, but rather the bouncy tissue that has slipped out and is pressing on the nerve. So the subsidence caused by disc changes is actually negligible because many always think there's not enough space, which is different in the cervical spine because there the discs are much smaller and the spaces between the vertebrae are also much smaller. But in the lumbar spine, it's not significant that it collapses, but rather that the bouncy cushion pushes through the gap that tears, causing the pain. Because the pressure moves outward and then presses on the nerve root, and this then triggers the intense pain. And Cauda nervus femoralis, octorotorius, ischiaticus, these are the largest nerves, and they are not hair-thin structures. They are as thick as a little finger. Oh, wow. Yes, so this is really large tissue, and you have to imagine such a bouncy ball-like structure is then as big as a thumb, and it presses with full force on this nerve, causing the intense pain that I then, to my distress, or perhaps as a stroke of luck, a twist of fate, or however one might call it today, also felt intensely. So the patients, I was kneeling in bed, tears were streaming down my face, and everyone out there, anyone who has experienced that can relate. We sometimes call it annihilation pain, and the patients can barely move. That's this lumbago. So then you say, stop, don't move anymore. The body tries to avoid it because there is imminent danger. And the spine is a central structure that belongs to the brain. It's a closed space, and the body tries to protect it. So that's why it's so important as we come back to this, how you handle this spine.
So, and now you invented a type of surgery for which you have gained worldwide reputation. What exactly was done there? Well, it's an endoscopic procedure. How can I imagine, to stick with the gel cushion and the ring play, what did you do endoscopically there?
So the knee arthroscopy has been around for a long time. Nowadays, no one would say, okay, I have a meniscus tear, let's cut open the knee, fold it back, and remove the meniscus. Everyone would say, that's what arthroscopy is for. With spinal endoscopy, the major challenge was that it's a very small space there. So we have about 1 square centimeter of space. And that's why back in the 2000s, in the early 2000s, we especially needed very small cameras. And at that time, the cameras were not yet, up until then, available. And then it became possible. These are cameras the size of a pinhead, so they are very small. The endoscope is 6.2 millimeters. And you can reach the herniated disc through the same hole where the nerve runs. So you don't have to, like with the... They also refer to minimally invasive for the microscopic surgeries, but that's not quite correct. You still have to perform the standard surgeries, which are still the norm today everywhere at Charité. Whether in Hamburg, Eppendorf, at the university clinic, it doesn't matter. Or in Munich at the university, where I also worked, they still punch out the bone, push aside the muscle, punch out the bone to reach the herniated disc, so you have to cause quite a bit of collateral damage to reach the herniated disc. With endoscopy, I go through the same hole as the nerve from the side, about 12 centimeters from the center, so not from the back. I guide this cannula and this endoscope through the nerve hole to the herniated disc and can remove the herniated disc with a small forceps, and the patients can recover afterwards.
Apologies for not sticking to my images, but I'll give it a try.
That's a drowsy cough.
You press the flumy tissue again.
Then back? No, I'll take that out. You're taking it out? With the pliers over the endoscope. Don't we still need that? No, so you have to imagine the outer ring is, and I also mean this previously with the distance, it's about 60-70% of the disc. The inner flumy core is maybe 30-40%. And it doesn't play a crucial role. The outer ring is more important. So that's why this tissue being removed doesn't really matter.
Good, I understand. It initially sounds like a good story because if you think about it, the distance is maintained. So my initial assumption, so to speak, is the vertebral crosses. So unlike with osteoarthritis, where you mentioned the bone structure, that's not the case here. Instead, the situation is actually like this, that this gel fluid leaks out, and as a result, it creates pressure in a place where it shouldn't be. You relieve the pressure, and with that, the problem is...
Initially solved. Initially solved, and with endoscopy, patients can stand up after 3 hours or go home the next day. With open surgeries, which are still standard today, patients need to stay in the clinic for 2 to 3 days because, of course, the collateral damage caused to reach the depth is much greater. Above all, a bone cut must be made. And this bone cut, this removal of the bone leads to bleeding, and the bleeding always results in scar formation. I introduced endoscopy in all the countries back then, but it did not catch on in Germany. In America, it is a standard procedure. In China, it is a standard procedure. In India, in Israel, in many European countries. In Germany, it is not yet a standard procedure. We also have an innovation backlog there because, of course, the endoscopic removal of a herniated disc is clearly advantageous compared to the still common open surgery today. And this scar formation is usually the problem, meaning that when normal surgeries are performed on the disc, the bone is removed, it bleeds, and this blood surrounds the nerve root. And that's why patients usually have relief at first. But after 6 months, they experience pain again due to the scar formation. But the fatal thing about the whole story is that the cause of the herniated disc has not been eliminated.
We'll get to that right away, but I know your topic because I also worked with Professor Karl-Heinz Kuck for a while, who also advanced the endoscopic heart valve surgery significantly, or even co-invented it, and it was also a matter of considering whether to open up the entire chest or do it endoscopically. Do I need to cut open the entire chest or do it endoscopically? Absolutely the same principle, same principle. I found the term collateral damage quite fitting in this context. The collateral damage is definitely much greater. Now, I just want to, out of my childlike curiosity, I often hear people who have had herniated discs and then had a fusion. How does that fit in? Yes.
It's actually another tragic topic because if you've had a disc surgery 2 or 3 times since the underlying issue isn't resolved, we'll get to that later. Bone is repeatedly removed. Bone at the L3, L4 disc, for example, at the L4, L5 disc, the vertebral body, the vertebral arch is punctured to get there. And this is also called a hemilaminectomy, which means the partial removal of the lamina of the vertebral body, as it was called in the 2000s. Today the access routes are somewhat smaller, but you still have to punch out bone. If you do this over 3 levels or over 2 levels, then instability. And that's why the patients are then fused. So for example, they undergo surgery 3 times, and then the surgeons say, because the recurrence rate is relatively high with open surgeries as the underlying issue isn't resolved, it occurs in up to 40% of herniated discs at the same site or at a different location, leading to a herniated disc in the body. That's why many listeners are certainly operated on multiple times. If it doesn't get better, then the surgeons propose a fusion where a plate is screwed over, for example, the 3 sites over the vertebral bodies to maintain the distance there, and eventually we reach the point where that this distance is maintained and somehow stability is restored to the spine. But initially stiffening doesn't sound particularly flexible. No, so that I can reassure the listeners, so when 2 or 3 levels are fused or screwed, the elasticity is hardly affected, but we have an adjacent instability. You have to imagine it's like a lever effect on the next segment. And as a result, we get instability there again, and that's why it often happens that patients then are fused level by level. And that's obviously a disaster because these are major surgeries, and if a screw isn't placed correctly, then the patient has to deal with it for the rest of their life, and the surgeons have to. This fusion cannot be removed again because there's that word collateral damage again. If you take it out, so much bone will be brittle and removed there that every surgeon says, well, if there's a fusion in there, then
If it doesn't absolutely have to be, then it's not removed anymore. I know this very well. I once had a scaphoid fracture in my wrist, and there's also a titanium screw in there. And honestly, when I look at the x-rays, it's more screw than bone. And you can imagine if you take it out again, then I'm back to square one. Yes, then you spread the bone.
Especially with the delicate carpal bones, that's a real problem, which is why I would advise you to keep them in there.
Yes, it hasn't been a problem so far. So far, it hasn't acted up. Oh God, hopefully it doesn't start today. You have in your book, we have a screwdriver with us and we can make a small cut and then take the thing out. Yes, to be honest, that's my favorite joke, but only the younger ones understand it when I always say I have the scaphoid bone and there's titanium in it. Then some football fans don't understand
Yes,
anything
we are
anymore.
probably Bayern fans, but now we've
Yes, me
already
too. Definitely not.
alienated 80% of the listeners, but I'm actually not a Bayern fan either.
Even though I'm from Bavaria. In your book, you described that almost 90% of back surgeries are avoidable. That's quite a bold claim. So why is there still so much surgery?
Basically because the connection is not known.
And knowledge.
Ignorance.
I
So
had
it is
now the
ignorance and, of course, the political system, one must clearly say that. The operational measures are much better represented in the GOR or in the EBM. And one must also say, the specialist in orthopedics used to be just the specialist in orthopedics, and then it was merged with the specialist in trauma surgery. And today it is called the specialist in, meaning specialist in orthopedics and trauma surgery. And in 2004, what essentially defines the non-operative surgeon, that is the conservative orthopedist, was somewhat lost due to the addition of trauma surgeons. And today one must say that 99.9% of all presentations at major spine or orthopedic conferences or congresses are only about surgeries. Go, as you describe them in your book. Yes, and 99.9% of people, including myself, would like to avoid surgery, and that's really heading in the completely wrong direction.
What was the biggest aha moment on your pain odyssey? Was there a key moment that really made you rethink?
Yes, so the key moment was the realization that it really got better. I have
This
through
device, I want to just...
this training, I mean, it was somehow unimaginable that it could get better or that this herniated disc could somehow change without having it removed in some way. And it got better and better and better, and I was completely pain-free, and I thought, if that's possible, I started my evolution from being a maximal operator, handling the largest fusions, big ones, then moving to minimally invasive techniques, truly endoscopic ones. And then suddenly I see, okay, if it's possible to become pain-free even without surgery, then I have to research this thoroughly and really get involved with it. And that's what we've been doing for the last 15, 20 years.
Honestly, I want to keep our listeners in suspense with two more questions because I think it's really important to understand where we're coming from before we dive deep into the solution. Many people truly suffer from back pain, but the causes are often unclear. Why is that? What are we overlooking?
This is really the most important question because you have to imagine that at the time when I got my herniated disc, I had no idea why I got one. So I was myself through this self-experiment, completely surprised by everything that happened. And what we didn't know back then and what most people still don't know today, which is why I wrote the book and really need to go public now, is that this deep musculature, especially the deep muscles of the back, plays a special role. In the past, there was a superficial layer and a deep layer. You can voluntarily tense the superficial layer. For example, if I ask you to flex your biceps, it's no problem. But now, if I ask you to tense the deep back or cervical spine muscles, give it a try.
I'm just considering whether I can control them.
It's not possible. The motor cortex can only tense the superficial muscles. The deep back muscles are controlled via the afferent spinal pathways and are involuntary. They cannot be tensed voluntarily. And that's the big difference. We cannot voluntarily tense the deep back muscles. And this is also the case because otherwise humans wouldn't be able to stand upright, so we need independence from these muscles. And the heart muscle is another muscle that is independent of the will. You can't tense it voluntarily either. And we've really worked out this connection, but it wasn't known before. The focus has been on physiotherapy and medication therapy, but the various muscle groups were not considered at all. And I stumbled upon it more or less by accident because I looked at the MRIs, but we know today that the deep muscles play an outstanding role. They are responsible for flexibility, elasticity, and protection of the spinal cord, the multifidus group, the ectospine. This is the muscle group, and it can only be trained in isolation. Normally, We don't come into the world needing power spine therapy or Dr. Alpine therapy. Usually it's normal to walk, stand and run. Enough training for these muscles. But, and this is the crucial point, if we develop pain. The pain can arise from a unilateral strain. In my case, it was likely that I would now operate bent forward. The pain can also result from a congenital change, such as scoliosis or a vertebral deformity. Congenital changes affecting the body's statics. The pain can arise from overexertion. We have many high-performance athletes whose back muscles are like those of 10-year-old children. These are triathletes who do sports for 5 hours. We currently have the High Rocks world champion. High Rocks is a high-impact sport. The back muscles, we can also talk about that. So the back muscles were like those of a young, like a little girl. Is that good or bad? It's bad if, of course, the deep muscles are so poor and not strong.
I wasn't exactly sure if 10-year-olds basically means, okay,
No, I just meant to say, if you take a 10-year-old girl and her biceps and compare it to a high-performance athlete with her
with the
biceps.
pinching press, you would beat them.
Yes, so what I'm trying to say is that this deep musculature was completely atrophied in this person. So the pain leads to sparing of the deep musculature. If the patients have no pain, no neck or back pain, they also don't experience any degradation of the deep musculature. However, the moment they occasionally reach for their neck or back, or when they work in the garden or something and then have back pain afterwards, they already have a certain degree of degradation of this deep musculature. And then the body starts to conserve that more and more. And the tricky part is, if you are, for example, a competitive athlete and have very strong superficial muscles, this system normally needs to be balanced. Then the deeper muscles actually become weaker the more you use the outer ones. And that's the paradox, because naturally we have many elite athletes or those who are very well trained who naturally ask, okay, how can it be, Mr. Alpen, I swim 3 hours a day, so is my back too weak? And I'm also a runner and athlete. I've done sports my whole life. That's why I felt exactly that way, was totally skeptical. And then we said, how can we prove that these deep muscles have deteriorated? And that's what our research focused on.
I have one of our Olympic swimmers, I can't recall her name right now, from Hamburg. She also had a slipped disc at some point, so she's also a Britta Steffen, I think, right? No, I mean someone else.
But she also had a problem.
But let's move towards a solution now. Your book talks about the 2-minute spine revolution. What's behind that exactly?
The idea is that you have to train these deep muscles in isolation. You have to do that with special machines. We have 35 centers here in Germany. At the Power Spine centers, you can do it very precisely. It's called Power Spine. Power Spine,
Like
yes. We
power
have
and spine.
written together DE, and there you can see the centers. We have developed software for these machines, meaning that when you enter size, weight, age, gender, and your diagnosis, the machine tells us exactly how to train you. This is the only system where we have diagnostic software for the non-operative system. The good thing is you train 20 to 25 sessions 2 to 3 times a week. There must always be 48 hours in between, and you really only sit on this machine for 2 minutes. There is one for the cervical spine, one for the lumbar spine. You push back against resistance and do 12 repetitions, which takes about 2 minutes, and then one training session is
Cervical gender,
you probably won't
not,
get
right?
injured,
No.
right?
So that means, theoretically, I could briefly incorporate it before or after the lunch break.
Absolutely. In other centers in New York, we've planned it now, and they're really eager about it because they can just sit on it in their jackets. And they don't have to do 40 minutes of exercises that don't reach the deep muscles anyway. And you do 20 to 25 sessions twice a week, and then it's stable, and this is actually the 2-minute spine revolution. You only do it once a month. Wow. Our patients, we've treated over 20,000 patients now, and a large portion, hundreds of thousands of these patients, only use this machine once a month. So they've optimized their muscles, and it's enough for this deep muscle to be teased just once a month. It's completely different with the biceps. If you take a break for 4 weeks, you can never lift the same weight again after those 4 weeks. This is the case with these deep muscles, and we've conducted a study on this because otherwise one might say perhaps every 3 months or every 6 weeks would suffice. But in fact, every 4 weeks is enough.
Okay, let's start briefly, just so I can imagine it. Let's assume I have a herniated disc. It probably starts from the top. You mentioned once the lumbar and once
Cervical
the back,
spine.
cervical spine. It happens in between.
The cervical spine and the cervical spine machine also affect half of the thoracic spine, and the lumbar spine machine also affects half of the
Not so?
thoracic spine.
Good.
Cover?
So you just look where you're closer.
Yes, you cover both. Usually you should do both machines, or you should do both anyway. Most people also have a restriction or weakness in the cervical spine, even if they don't yet
Feel it. Good. So that means I make an appointment, then I go there, and then I might come, for example, with my diagnosis. Then I sit on this device, and then how do I imagine the exercise itself? You mentioned about 25 units, but what exactly do I do there? So in most...
In many cases, we perform a test beforehand, so you press statically against the resistance and check at various measurement positions how strong the muscle strength is. A curve is already created, and then you can already see how strong you are compared to the average population. That was quite interesting with the professional athletes, also with the ski people. Mr. Mayer is also described in my book. And they were completely perplexed that they had such relatively poor curves. I also found it to be below average. Me too. You can imagine that I was also totally below average because back then these kinds of tests didn't exist. We developed this therapy from all this data. You have to imagine that since 2002 we have scientifically researched and recorded all patients. So these are thousands, hundreds of thousands of data points. Our students alone spent 3 years digitizing this manual data and inputting it into the software. So the machine is one thing, this fixation, you're fixed, pushing back against resistance, and there are many of our listeners who are definitely in the gym and have a machine where they have a strap in front and are somewhat fixed and push back. With the two machines, the pause bind machines, it's optimized. So there's a huge difference compared to regular fitness equipment. You really can't assist with the gluteal or thigh muscles when extending backward. And with this, the deep muscles are isolated. And with the cervical vertebrae, it should be exactly the same. You then sit like in a chair, it's fixed over the chest forward here, and you then push back against resistance. You always start with very small weights and very small ranges of motion and gradually increase until you reach the optimum of your own strength. At some point, there is a limit that we always reach because we keep increasing, and there is also an algorithm for how to do it exactly, which is also defined in the software. And then the muscles are optimized. When these muscles are optimal, the pressure on the intervertebral disc is no longer present. That's the problem. That due to the lack of deep muscles, we have enormous pressure on the intervertebral disc. When these muscles are firm, when the spine is stable, then the pressure on the intervertebral disc and the herniated disc is no longer there, and then the body can break down this herniated disc on its own.
That would have been my immediate question. So if I stick with my gel cushion example, there's the ring around it, the ring breaks open, then the fluid comes out pressing on the nerve. So, and at the moment when I then basically... The gel cushion with its outer ring is relieved, so to speak, because the deep muscles essentially take over the work. So to speak, the fluid can be reabsorbed.
The body can break it down with macrophages, with phagocytes. And I also have in my core studio, which is also documented in my book, the incident is completely gone. The last result was that this massive prolapse of 13 millimeters was simply no longer visible. May I briefly ask again, a massive prolapse simply means...
It's huge.
That it was no longer...
That means there aren't several, but just one, and it's significant.
Visible. In normal cases, they are between 4 and 6 millimeters, and mine was over 13.
Okay, wow.
But then they
But
are
then
there
you were
to
at least above average.
see... Yes, that was when I already said.
If I already have it, then properly. Okay, but excuse me, I need to, you did mention it earlier, I just want to emphasize it again. It's important to briefly note it down. We have now determined we are going into this machine, then we will do this exercise. This exercise takes, despite everything, these 25 repetitions, it takes 2 minutes in itself, you say. Yes, of course you have to change, that is...
The whole setting now takes maybe 20 minutes. You have to adjust it. But the training itself takes 2 minutes on the HBS, on the cervical spine machine, on the lumbar spine machine. And you do that 20 or 25 times, then it's set. And over what period? 18 to 25 sessions. So at best, they can do 3 sessions a week with always 48 hours in between. So typically with 18 sessions, it takes about 9 weeks. If they do it 3 times a week, it goes faster. We also have NBA athletes from the USA and so on who don't have much time. They rent hotels and try to do 4 sessions a week to optimize it, but we have seen that without stress, or twice a week is actually the
best. Okay, and what would you say? From when could one start to expect results? Probably depending on the prolapse, but what would you say? When can I expect the first signs of improvement? So
we already set the patients with the greatest pain in there, so we see that just the blood circulation in this region through the machine, because that doesn't happen at all otherwise. It doesn't happen with the other therapies. I'll get back to that in a moment. But just by the removal of pain mediators, patients already find it pleasant to just sit in this machine. They can't imagine it at first, this Marshall thing. It has a ton, it's really massive. And then they are even afraid, but those are just very small weights. Then you do it in a small range of motion, and then they are fixed, but then they gain more and more trust. And actually, after 4 or 5 sessions, it already gets better. After 6 to 8 sessions, significantly better. After 12 sessions, much better. And after 18, it should be at least much better, so a 70 to 80% improvement. I mean, one must also say that herniated discs are just one part of spinal patients, listeners. There are, degenerative facet joints. There's spinal stenosis. So there are many other issues, although herniated discs are particularly well known. Herniated discs mainly affect the younger patients because they naturally don't have any changes in the vertebral structures yet, as they are still so young. Nevertheless, if the pressure on these discs and the vertebral body increases over time, it leads to all the changes that occur later, and that one absolutely should be treated with therapy, because the vast majority don't have any deep muscles at all, as the pain has caused them to deteriorate. We also know from research that the deep muscles are always the first to deteriorate. There are also recent studies from Denmark and the USA. Yes, and today the deep muscles are not at all, well, not yet,
really taken into consideration. If I now return to the treatment, we have these 18 sessions, or these 18 sessions, as you mentioned. We have now completed these 18 sessions. So, and then you said that afterwards I should only do these 2 minutes about once a month. Is that even correct?
99.
Yes. Good. And then you said that this really affects people with all kinds of back pain. That means for me, fortunately not for years now, knock on wood, but I had a bit of this SI joint problem, which means this connection where basically the sacroiliac joint, so to speak, the connection of the spine with the pelvis, to put it simply, I would say. So that means it seems to be a weak spot for me. Is that something I could address with this?
0.9% don't have an SI joint problem, absolutely.
Okay, what do I have then?
Just like fibromyalgia. That's also a kind of placeholder diagnosis or ADHD in children. There is no real etiology of how it is composed. The SI joint is the ilium scapular joint, sarcoma joint, sacrum joint. It's a huge joint, and it sometimes shifts by micromillimeters, and even in an MRI or X-ray, these shifts are barely visible. They can occasionally trigger pain. Most of the pain occurring in the area of the SIJ is the radiation of the sciatic nerve, because the starts exactly back there and then runs over the SIJs, that is, over these areas downwards. And that's why it's always considered an SIJ blockage or SIJ pain. From my experience with thousands of patients, it is very, very, very rare that it is an SIJ or ISJ problem if you swap the letters. But in most cases, it is due to an instability of the lumbar spine and pressure from the discs on the sciatic nerve, which runs over the SIJ. This means you can certainly already detect a huge deficit in deep muscles just from the statement that you have SIG pain or SIJ pain.
Had years ago, many years ago. Maybe I've slowly caught up a bit with the 10-year-old girl. But what would you say are the most common mistakes people with back pain make? Are there typical no-goes?
The mistakes most people make are ignoring the pain. Pain is simply a safety measure of the body, indicating that you shouldn't do something. This means that sometimes we resort to painkillers or cortisone or the German pain league, which is relatively reduced, also with antidepressants or with medications that have a relaxing effect. We try to tackle the issue. This also improves the pain with the escalation of painkillers. And we do things that one normally shouldn't do, where the body would actually say, I'm giving you the pain so you don't do it. So a painkiller in the first phase is certainly just fine to be able to get up, but by no means a therapy that should be done long term. So we can't say, we'll just keep taking ibuprofen and it'll be fine, because this naturally encourages you to continue sparing those muscles, leading to further muscle deterioration. Another problem is when you have axial pressure from above, which triggers a compression. You can imagine what might trigger the pressure, which is unfavorable for the intervertebral disc. It's also not beneficial to jog, as it doesn't contribute to the deep back muscles. Perhaps a sentence that is very important, one that might describe it. Physical therapy, physiotherapy, massages, homeopathy, acupuncture, sling table, heat staging, injections, EMS training, yoga, Bach flower therapy, mud packs, injections. Surgeries, these are all things that positively influence the symptoms, and they cannot be dismissed or denied. But the cause, according to our research, is always the degeneration of the deep back muscles, so it is definitely related to that. If you have never trained these deep back muscles, you have never undergone causal therapy, and that's why osteopathy, where the vertebrae are mobilized through manual therapy to achieve pain relief, or the manual therapy with chiropractic. These are all things that are wonderful. We work closely with osteopaths and physiotherapists. But they need this deep musculature. That's why patients always, and it was the same for me, are not sustainably pain-free. They always think, okay, 3 months have passed, I'm actually feeling pretty good, I'll go to my osteopath who will realign me or move it properly. And then when they drive on a bumpy road or really hit the gas like they used to or play soccer, they suddenly find themselves back in the corner saying, okay, shit, I probably can't do that anymore. But they all lack this
Deep musculature. A big hype in Berlin, Hamburg, but I think in many other cities too, is this Lagri or Reformer Pilates thing, because it supposedly also targets the deep muscles. Do you have experience with that?
deep muscles. Yes, well, it's certainly a wonderful therapy, but it, according to our research, does not reach the deep muscles. We conducted MRI research, EMG research, because it's also about facts. So Qigong is an EBM service covered by statutory health insurance, meaning a statutory service, the Chinese martial art. And there is no study showing that the Chinese martial art trains the deep muscles. So everyone, and I mainly wrote the book so that it finally becomes a statutory service. But all these therapies, which I also examined in the previous book that didn't become this book, do not contribute to the deep muscles. You need to isolate these deep muscles. Nevertheless, I am a fan of Pilates, yoga, and also what Liebsche Bracht does with fascia exercises. That's all wonderful, but for heaven's sake, you need this deep musculature.
No, I understand. What I find quite interesting is that I once had Ingo Froboese, Professor Ingo Froboese, in an interview with me, and he always gets really angry when people say, yes, you have to protect your back. So he says, yes, of course, when the pain is really acute, yes, but if you then start only protecting it, that's the worst thing you can do. Would you agree with that? Absolutely.
So we are an inactive society, and we wouldn't have any back pain or back issues if we
would move normally. Interestingly, that's my next question. So would you say that the lifestyle is simply to blame for this? Absolutely.
move. The human is a creature of movement who used to walk, jog, run, or go for 12 hours. And today we sit for 12 hours. And that's why it's changing so dramatically, and it will increasingly go in that direction, meaning more and more sedentary jobs exist. In that respect, the colleague is absolutely right.
How would you view a classic piece of advice like sitting upright, for example? Is that still relevant or rather outdated? I don't want to
say it's absolutely outdated, but I would say it's absolutely outdated.
Okay.
So we have studies that show that when you, and I want to emphasize again, everything I'm telling you here is not based on any anecdotal stories, but we have a huge team of researchers there. So we ourselves are a small team, but we have collaborations with universities in Sweden, in Canada, and so on. And many are now jumping on our research, especially on the core muscles. The fat accumulation in these deep muscles can be seen in MRI scans. We should briefly discuss that again. But everything I'm telling you now is based on research. And if there isn't proper research, of course, a change is good. Standing and sitting. What did you just say about the fat accumulation? Yes, that's another crucial point. So if these deep muscles are not properly engaged, they become fatty. That definitely doesn't sound very appetizing at first. So this, and that's actually how I found out, because I always, well, it's like this. I'm also an MRI radiologist. I did a special training in that, not a specialist, but I always dealt with the MRI images of back patients, and also with my own MRI to see if I could find anything that might explain it, because I had the incident. And you can see in patients, there's the superficial layer, which you can see in the MRI, and the deep layer. And normally in the T2-weighted MRI image, which is simply a staining technique, fat tissue appears white and muscle tissue appears black. And you can see in people who now have poor deep musculature, a proper white layer, meaning we have fat cell deposits in the muscle layer in the multifidus. This means the patients, if the muscle, for example, if they leave the bicep idle here, then eventually after 4 weeks, if they don't move, so much fat will accumulate that it would all be white. Muscle tissue will then transform into fat tissue. And this is also the case with the deep back muscles. And that's why, and this is significant, you can see it in all patients, we have a degeneration of the deep musculature, which appears as a white area. That's why we can also advise our listeners, if they have a CD at home, to insert it into the computer and call up the T2 or the sagittal 2 image, at least where you can see white areas. And there they will see that the deep layer, which lies directly on the vertebrae, is white, and that is a fatty degeneration of the deep muscles. Today we can measure that this deep musculature, when isolated and trained with these machines, which by the way can only be done with such machines and not at all with physiotherapy, that these fat structures dissolve again, that they become less. And in the ultrasound research, which we have also developed over the last 7 years with a doctoral thesis, we can demonstrate with ultrasound that this multifidus group, that is this deep musculature, swells. And it does not swell with other therapies. It's about effectiveness. If we become completely pain-free with Bach flower therapy, then we can drink tea all night long. I have nothing against that. But we must finally to achieve a pain-free patient, and we won't get there if the deep muscles are never trained.
What do you think about ergonomic office chairs, special mattresses, or all those gadgets that are supposed to save your back?
That's a good question. Well, I think that a water bed, for example, I'm often asked if the back is stable. If it's really firm, it doesn't matter at all what you lie and sleep on. You could lie on a wooden board, it wouldn't make any difference. If you have a severe scoliosis, for example, a curvature of the spine, and you use a waterbed, the waterbed will conform to the shape of the scoliosis, which is rather unfavorable. Otherwise, anyone with a waterbed and no scoliosis, no problem. However, it also doesn't contribute to any changes in the spine. What really matters, or what is truly sensible, is, for example, changing positions while working. What really matters, or what is truly sensible, is, for example, changing positions while working, that we don't just sit all the time, because when sitting, the entire pressure is particularly high on the lower 2 vertebrae on the half axis. And that's why alternating between standing and walking is sensible. That's why workplaces where you can adjust the desk make sense. Standing, and I even have a walking pad underneath. Yes, that's all very good. But as I said, I believe that if the back is stable, we wouldn't need many of these things.
We wouldn't need many of these things. Well, Very good, very good. Many people are also afraid of a herniated disc because they believe that nothing will be the same afterward. How much truth is there in this fear? So I would say, based on everything I've heard so far, you can kind of take them, right?
So the question was whether the fear is there or whether the fear goes away. So the fear, it's there and it's brutal. That's really what has changed my perspective by 180. As Ms. Baerbock would say, 360 degrees. 180
Yes.
degrees. Okay, that's what I mean now.
Just like
Anyway,
that.
that has really changed everything completely. Is this pain, and you can and should be afraid of it, but I can, especially with the, and we might briefly touch on the cervical spine, but we also have a huge problem with tinnitus, migraines, and headaches. And if you also consider the muscles in the cervical spine, the instability of the cervical spine is a cause of migraines. I can already give people great hope that many of their pains will disappear and those who are completely desperate. I have also described a few patient examples in the book, where even very young patients who have been taking triptans or strong migraine medications for years experience significant improvement after just a few sessions, eventually becoming completely pain-free, and then sit in front of you crying. So, I don't want to spoil it, but this is a story from the book, and dramas unfold, dramas of joy. So, I actually want to call out to all people, the surgeons, the people who deal with the spine, and who all have their expertise. And no one wants, in the end, everyone tries to make the best of it, even the surgeons. But we are missing a very crucial point, and that is the deep muscles. And I believe that if patients have the opportunity to undergo this therapy, that 70–80% of the complaints will then improve.
I would like to delve into the topic of migraines again. For example, my wife has been dealing with it for many, many years, and for her, a significant trigger seems to come from the cervical spine. So from the neck area, as she perceives it. She always goes to the chiropractor, who then performs an adjustment. So she does this often. So what is your perspective on this?
In the USA, chiropractic is recognized as a legitimate profession where the cracking sound is often seen online as a sign of success, that it's going quite well. And indeed, when you adjust someone at the cervical or lumbar spine, it's a capsular vacuum sound, this pop, which is a capsule, and when this joint realigns, it produces this sound. The reason these small joints are misaligned is due to instability in the deep cervical spine muscles. So, you can't keep adjusting people if these deep muscles aren't stable. That's the logical conclusion. We have instability, okay, we adjust it, but we don't achieve stability. We keep making people softer and more flexible, and they end up like rubber people. And your wife, she's been adjusted very often now, which means these small vertebral joints are already somewhat lax. They urgently need this machine. My wife also had migraines. Welcome to the club. You know how hard that is? We have a total of 8 million migraine patients in Germany, 8 million. And if they even remotely, we know from our research that 60–70% of migraine patients suffer due to instabilities, specifically due to the instability of the deep cervical spine muscles. So if these 70%, that's 5 million, if they even remotely knew that they could achieve improvement or even complete pain relief with such therapy, then everyone would immediately start with this therapy. And that is, and I experience it every day that people come and say, Mr. Alfen, if I had known that, that's why I said, okay, we were in politics, we were with the health insurance companies. I spoke before the parliamentary committee, so I am the president of a scientific society. So I have already tried all levels to bring this therapy into play and also the meaningfulness, until I thought now I have to go through the public. Write the book, because it can't be that millions of people don't even know about it, where perhaps their solution could be.
I would also sign that after everything I've heard so far. I would like to address the point again that also It is very common that people who experience a lot of stress are very tense and often tend to eventually suffer from a herniated disc as a consequence. Is that a coincidence, or is there actually a correlation?
There is definitely a correlation. Pain is always multimodal, and as we've already seen, pain is the trigger for the breakdown of the deep muscles. Pain, rest. This means that pain can originate anywhere and then essentially discharge along the spine. Everyone has their own system that reacts to psychosomatic or stressful situations. Some girls sometimes get a bladder infection, others get neck pain, and others have recurring different issues. The back is very often affected because it is a nerve structure that is naturally connected to the emotional center.
You can really see it when people feel tense.
We have seen a massive increase in these complaints due to looking at phones. It's like placing a crate of water on your neck. That's 22 kilos of pressure that the children have to endure. So an army of billions of people is growing up with unstable cervical spines, and you can't fix that by just doing something. They have to do it against resistance with weights, and it has to be very targeted. There also needs to be software behind it, because we now have 12-year-olds with headaches and 16-year-olds with herniated discs. I just had a patient who is 19 and has already had 2 surgeries. She came in here hunched over. I said she needs to have endoscopic surgery now. She's already had open surgery twice. I said, we're not going to operate at all now. We're going to optimize the muscles first. They became completely pain-free. So that's 1 in 100, not 100,000 stories, because in centers there are already hundreds of thousands of patients who have been treated more, and we have very similar results everywhere.
I find it quite interesting. I don't know how often you are in London. I used to be there almost every week for a while and would always go jogging in Kensington Hyde Park, and there's the Royal Albert statue. It's across from the Royal Albert Hall, and for all listeners who happen to be in London sometime soon, they should take a look at the Royal Albert statue from the side, because even the Royal Albert in this statue has a smartphone neck. Honestly, I find it quite funny how you can make a sculpture of a king who is actually sitting with his neck bent forward as if he's looking at his phone. Yes, so...
We also call this the text neck phenomenon and smartphone neck, but it's actually a huge problem, and that's why kids get headaches. I mean, I have 2 17-year-old twin daughters who, of course, spend a lot of time on their phones, and you can't avoid it. And if you're so efficient, you can also take measurements with our machines using the power spine system. So you can see how the value compares to the average population. And then you could also work preventively, of course. One could place the machines in schools and we could immediately measure, because it said, okay, you don't have a problem yet, but you could develop one. Of course, wheelchair users need this because they might suddenly be able to play basketball again. Because naturally from T7 onwards, this paralysis can be treated very well with it. The scoliosis centers need it. Bayern Munich needs it. The ice hockey players need it. Everyone needs this deep musculature. And we have now established a huge industry on how to avoid it, how to manage it, because we simply didn't know the causes. It's like finding the philosopher's stone, like slaying a dragon, and the hero then goes home back to his village and says, yes, he has slain the dragon and it was incredibly exhausting and he tried everything and in the end he was there and then he's with his people and then the people say, we don't believe you, that's not true about the dragon. That's how I sometimes feel. We have such a huge thing and no one knows it, no one takes it seriously. No one sees it, and at some point, when I also spoke in the parliamentary committee, they eventually said in 2017, Mr. Alfen, oh, it's all well and good, but we need more studies. But the other therapies also have almost no studies. And I say, okay. Then they all closed their books and said, because they knew that was the end of their workday, more or less. They don't have to decide anything. They don't have to consider whether it makes sense to continue. Pursue. And then I started to build a research team. Because I said, okay, then I'll also do research if it has to be done. And now we are at a point with the book where I can say, okay, there is no doubt anymore. And no one will stand up now and say, yes, my wife rides. That's definitely great for the back. It's good for the back, but for the outer back and this distinction with the deep back, that's actually the outstanding part.
Well, let's take me as an example. After I've been treated here several times, I don't have back pain in the area. I apparently didn't have an SI joint issue, but I did have this problem some time ago, so it's really been at least 10 years now. Nevertheless, no problems. Should I still go to Power Spine, get measured, and possibly start training?
Definitely. It doesn't hurt to take a test, and it costs almost nothing. It's not yet a statutory service, which I'm trying to change. 90% of Germans do not have access to this service, but the costs are manageable. Everyone would have their car's scratch fixed, spending 1,200 euros spread over 3 months. It makes sense. But with the test, you can determine it immediately. And how much does the test cost approximately? 50 euros.
Oh, very manageable.
Yes.
There are
Or
other
60
people
euros. 50, 60 euros.
There are
But if
other
we go
people.
out to eat now, you can see in the MRI, you can see the muscles fat infiltration. No, you really don't have to. That's why imaging techniques always have the disadvantage that patients suddenly have a diagnosis in their heads. If we were to do a core test on all people in Germany today, 90% of them would show changes, which might then be turned into a diagnosis and subsequently treated. So I'm not a fan of too many imaging techniques. We need to examine people, just as Müller-Wohlfahrt rightly says. We need to examine them. We've all forgotten how to perform these examination techniques, to work with our hands, and so on, and other options besides this imaging technique. Then the diagnosis is made and the whole process begins. And in Germany, if you've had pain for 3 months, it's such that then it is advised that if things don't improve within 3 months, then surgery should be performed. And that is a mission impossible, because you can't become pain-free in 3 months, especially when it has developed over years due to the gradual deterioration of the deep muscles. Has developed.
We always talked about how 90% of surgeries are avoidable. So what are the 10%?
The absolute indications for surgery, which include, for example, bladder and bowel disorders, meaning if the bladder is affected by the T11, I don't need to list the nerves exactly now, but they are supplied by various systems in the spinal cord. If you have a bladder or bowel disorder, then surgery is necessary. For the bladder, surgery must be done relatively quickly, because if the bladder doesn't empty within 8 hours, it can lead to significant damage. Bladder and bowel disorders, intolerable pain over a long period, but I'm talking about a period of more than 3 months, much longer than 6 or 7 months. If you have extremely severe pain, then the herniation is removed. Ideally, this is done endoscopically, followed by rest. Motor weaknesses, meaning that you have sensory disturbances. This is not an indication for surgery. So bladder and bowel disorders, intolerable pain, or motor deficits. This means you can no longer squat. That can be tried at home by everyone. Stand on one leg and go up on your toes and heels. This already checks the last 3 levels, as the last 3 discs are the most affected. So if you can stand on one leg and go up on your toes and heels, then it's not an indication for surgery. In the cervical spine, the radiation, we have quite a lot of shoulder injuries that aren't actually shoulder injuries, because this radiation of the dermatomes is often misinterpreted in diagnoses. If you can no longer hold the glass, if you have a drop hand, then these are motor paralysis, where the nerve is under so much pressure that it needs to be relieved.
But it's often the case that initial neural deficits are already present, that you somehow no longer feel the little toe.
The sensation is not an indication for surgery. Definitely not.
Means...
So, would you say it will come back? Yes, definitely. We even have cases with motor weaknesses in the arm, where if the cervical spine and disc retract or degenerate a bit, we have patients who have experienced weakness, and then they no longer have any weakness. And one more thing that might be important is all the radiations. People undergo catheterization on the heart because we have radiation in the heart region that originates from the thoracic spine. Or they have intestinal pain, constantly undergo gastroscopy, and have nothing wrong with their stomach. These are all spinal nerves that originate from the back. So always spine first. Optimize the deep muscles, the back, and then see if there is even perhaps a gastrointestinal issue. I don't want to discredit my colleagues at all. Certainly there are also changes in the cells and so on to be seen. But if it's not really significant, then you always have to consider the spine.
If someone is listening here now, they will surely have their trusted doctor. The doctor he trusts has already scheduled a surgery date and said, no, sorry, what Alfen said there, on the radio, in quotes, or wrote in his book, that's all quackery. Nevertheless, then someone says, yes, but before I really go ahead with something like a fusion, which is, let's say, something quite crazy, which she loves, that's just how it is. Would you now say, okay, what do you do then? Come for a test. Or what would you say?
Well, I would hope that the colleague can be convinced, because a doctor, even if he operates...
Because actually we hear from the patients, let's say, so only the patient now has the chance to, so to speak, jump off the operating table.
Of course, as long as he doesn't have any absolute surgical indications, which I just discussed, definitely take a test. He doesn't need to take a test at all, because if he's in severe pain now, we won't necessarily do the test either, as it would also be a strain. Then we know if he has back pain, he definitely has severely weakened back muscles. And he should visit a power spine center as soon as possible, and we'll start very gently there. It's not like that. There are also 10% of patients who don't become pain-free, or 15%. It's not the be-all and end-all where one says it's the absolute best for everything and it's only this method. But the deep muscles play an outstanding role, and most patients who then come to surgeries or alternatives have never trained these muscles. That's why you can only tell them spine first, make sure it reaches those deep muscles. You have to isolate them, and that can only be done with such machines. Unfortunately, it's like this. I'm always asked if there aren't 3 or 4 exercises I can do at home that will somehow help me. There are hundreds of exercises online that are good, ones you can enjoy doing. But the deep muscles can only be trained in isolation. We wouldn't normally have any problem if we weren't such a sedentary society. Ötzi, as I said, had declarative changes, which is also a topic of my book, but he didn't have any major herniated discs. This is really because we move far too little.
When I return to the migraine patients, it's often the case that they are always very worried about trigger points. And one could say that addressing the muscles could potentially lead to some kind of muscular reaction. Have you experienced something like that?
A very, very good point, because otherwise it might be misinterpreted. You are absolutely right. When migraine patients use our machines and start pushing back, one must be very cautious. We really start minimally, because they immediately get an aura or say, okay, that didn't do me any good. It's often the case that we need to be really close to the patient for 2 or 3 sessions, and they have to endure this valley of tears. If it's somehow possible, and they shouldn't just say, okay, I've done 3 or 4 units now, I've even just triggered a migraine case. This happens more often, but if we can get this instability under control, then for 70%, 60% of patients, it's much better. And that's why today is a good day, because I want to put this hope out there or call out to people. Because it's unimaginable how it is, even as a doctor, when people feel better and they really become pain-free. It's incredible, especially with young people. We have more and more young people. Of course, with migraines, you also have to consider postmenopausal, premenopausal, the hormonal situation, but you also have to see that, for example, painkillers, estrogen and testosterone reduce, and thereby, for example, osteoporosis develops. So there are many connections with the spine. In this respect, one must pay special attention.
Happened? I believe that everyone who has listened up to this point will definitely see it that way. And exactly what you say, I keep meeting people on the street who somehow thank me for helping them through these interviews to actually become pain-free or to live healthier and better in another way. And I am quite sure that many people will hopefully do the same after this conversation, following your advice. Therefore, my final question is, if we had to summarize the method in one sentence, what is the most important insight you would like to share with our listeners? Spine first.
Without the deep muscles, patients unfortunately cannot become sustainably pain-free.
I say thank you very much for the conversation. For everyone who wants to learn more, there is indeed significantly more to discover. The name of the book, I actually have to read it again, The Spine Surgeon Who Couldn't Operate on Himself, was published by our publisher. And there you will find significantly more for all those who want to learn even more about it. And I say thank you very much for the conversation. Yes.
Yes, I really enjoyed it, and I hope to reach people with this message. I will not stop until this therapy is available to the entire world.
Do you actually have a favorite supplement?
I'm here now at Sunday Natural, and I already said at the entrance, without wanting to say anything nice to anyone, without knowing them, that my family, especially my wife, has been dealing with the topic for years, and then 3 years ago, I believe, came across Sunday Natural. And we really, including my twin daughters, have been taking it regularly every day. And I'm a big fan of this supplement, not because we're sitting together and don't know each other well yet, but because it's simply a fact. And by the way, this is the malnutrition of the Germans, and I'm also in longevity. I'm kind of involved in that area. Of course, exercise and nutrition are the two main components of how to extend life. And we see in older people, they are not demented because they can no longer solve a Sudoku puzzle correctly, but because they are malnourished and have deficiencies. It starts with omega-3 fatty acids in the morning and continues with other micronutrients that are simply missing. And this is a vast area where one can greatly improve people's quality of life. In this regard, combining it with Spine First is, of course, optimal.
If you enjoyed this episode, it would really help me if you left a review on Apple Podcasts or Spotify.
To make sure you don't miss anything, subscribe to our newsletter. It's not just about this podcast. We usually introduce brand new products there, which always come with an introductory discount code, but it's only valid for 24 hours, and it would be a shame to miss that. You can find the newsletter at www.sunday.e/newsletter.